Welcome to the Africa Stigma and Discrimination Forum 2020. Kainses, this is a traditional Kwek greeting from my native language in Namibia. Thank you for making time. Thank you for being in attendance, especially in the time that we are having so many competing priorities happening, and in a time when we are all battling a global pandemic, as we all know, COVID-19. My name is Helen Kambinda. I am the director of Positive Vibes Trust in Namibia, and I'm also pleased to introduce Mark Nielsen, who is a consultant physician at Chelsea and Westminster Hospital and the professor of HIV medicine at Imperial College Medical School, where he's also the senior tutor. Mark will be my program co-chair, and he is also the program chair of the Stigma and Discrimination Program Forums that has been held globally this year. So as you know, there's been an Asian forum, there has been a Latin American forum, and I'm happy to co-chair this with him today. Today's program has 3 sessions, an opening session. And in terms of the opening session, we have got some great speakers lined up. Session 1, after the opening session, will deal with barriers for key populations to access comprehensive services in Africa. Session 2 will deal with what does SRHR mean in real life, a community perspective. And as usual, we have also some great speakers lined up for the session. We would like to thank our educational partner, Erasmus MC, as well as the endorsers of the African Stigma and Discrimination Forum for 2020. The African Stigma and Discrimination Forum 2020 is supported by an independent educational grant from VIV Healthcare. It's also worth noting that VIV Healthcare was not involved in the development of content or selection of faculty for this educational activity. Your feedback is really, really important to us. We want to know what you think, what your contributions are, and your perspectives are during the forum. And after the forum, a short survey will be sent to you via email. Please complete it. And we are also happy to let you know that you will receive a certificate of attendance. Again, your feedback is valuable and helps us also to make various improvements to strengthen the program in future. In terms of the question and answers, please make sure to ask any questions to our speakers and panelists during the discussion panels. To submit your questions, please add them to the Q&A box in the Zoom window. Again, I thank you, and let us make this forum a great participatory session for today.
So we're going to start the forum with the fantastic speaker, Amanda Castell, who spoke at last year's forum, and this year is going to present on what works to reduce HIV-related stigma and discrimination and how this can apply to COVID-19. Amanda works at the George Washington University in the United States, where she is professor in the Department of Epidemiology and Biostatistics. She has a really good track record of looking at and conducting studies in technology-based interventions aimed at improving and indeed have improved HIV testing, engagement in care and treatment adherence.
Hello, I want to thank the conference organizers for inviting me to give this talk. Over the next few minutes, I will provide a brief overview regarding the novel coronavirus pandemic and responses, discuss some of the stigma and discrimination that has resulted in that response, highlight the synergies between COVID-19 and HIV, and discuss how our experiences with HIV-related stigma and discrimination can inform our responses to the COVID-19 pandemic. It's hard to imagine that only 10 months ago, a pneumonia of unknown origin was detected in Wuhan, China. The Chinese government acted relatively quickly with identification of a novel coronavirus within 7 days of detection. And by January, a public health emergency of international concern was declared by the World Health Organization. By February, the virus had been identified as COVID-19, and in mid-March, the WHO declared a global pandemic. As of today, there have been more than 50 million cases of COVID-19 reported globally. The distribution of the virus globally has disproportionately impacted some regions of the world more than others, including the Americas and Europe, as you can see here in this graph. Interestingly, the African continent has been relatively spared compared to other regions of the world, with approximately 1.3 million cases reported, or about 2.5% of the global number of cases. The response to the COVID-19 pandemic has relied on several traditional public health approaches, including containment strategies such as contact tracing, isolation, and quarantine. Strategies which have been used with other infectious diseases such as HIV, sexually transmitted infections, and Ebola. However, as the transmission rapidly outpaced containment efforts, we've really focused also on mitigation efforts, including the development of non-medical interventions, as well as application of non-pharmaceutical interventions such as school closures and social distancing. All of this has been implemented with the goal of flattening the curve to minimize the overall number of infections and spread, and to protect healthcare systems from being overwhelmed. So how have these efforts resulted in the emergence of COVID-19 stigma and discrimination? Well, more specifically, COVID-19 response efforts have included restricted air travel and closing of borders, issuance of quarantine and stay-at-home orders, as well as social distancing, closure of schools, universities, and non-essential services, and establishment of surveillance systems and contact tracing workforces, as well as testing and expansion of testing for COVID-19. And while the rapid implementation of these efforts was successful in curtailing the spread of the virus in many countries, it has also had what some might consider to be unintended consequences. For example, closing the borders resulted in xenophobia, racism, and discrimination. The quarantine and social distancing orders resulted in many persons being socially isolated and lonely, disruptions in the receipt of care, and importantly, the propagation of mis and disinformation due to a reliance on social media during these lockdown periods. By closing educational settings and non-essential services, younger people were likely protected. However, this meant that essential workers, who are often the most vulnerable and socioeconomically disadvantaged, were still required to work and were put on the front lines of the pandemic. And public health measures such as contact tracing resulted in further stigmatization, reluctance to share important information with health officials, and testing expansion and access was often unevenly distributed, further exacerbating inequities in healthcare access. So these consequences are not novel to the COVID-19 pandemic. As the World Health Organization describes, often in outbreak situations and epidemics, people may be discriminated against because of a perceived link with the disease. The stigma around COVID-19 was likely worse because it was a new virus, and we didn't know much about how it would affect people, and that results in fear of the unknown. And as we often see, that fear then gets translated into a disease being associated with others, resulting in social stigmatization, othering, labeling, and stereotyping. Stigma interacts with underlying racism, ageism, cultural differences, sex and sexual orientation, health status, poverty, and many other structural factors. And as a result, we observe barriers to testing, less health-seeking behaviors, and therefore poorer health outcomes, including mental health. So as I've mentioned, what we're observing with COVID-19 is not unique, and it's not new for those of us working in the field of HIV. In fact, there are quite a few synergies between the two viruses. Many of us in the field are starting to reflect on this. And as you can see, these are just a few articles highlighting the synergies between HIV and COVID and how we might learn from these past experiences with HIV. As we've learned more about SARS-CoV-2 or COVID-19 and how it interacts with HIV, the World Health Organization and other governing bodies and organizations have issued interim recommendations and guidance on management of people living with HIV during COVID. What we are still examining, however, is the impact of the pandemic on the HIV care continuum, a topic that will be discussed in depth at a later talk. While there are still many unknowns, this table attempts to summarize and compare some of the key characteristics of COVID-19 and HIV. Virologically, we see commonalities between the viruses, including animal hosts, high numbers of infections and deaths, and high mortality rates. However, we've seen a distinct difference with respect to mode of transmission, incubation period, and symptomatology, as well as the overall geographic burden and distribution of disease. Importantly, neither virus has an available vaccine currently. Thus, identifying those most at risk and instituting prevention efforts are key to epidemic control. We see that prevention of COVID-19 has taken on a similar approach to that of HIV, with testing, contact tracing, and behavior change being key strategies. It's also important to acknowledge that there are shared experiences with respect to these two pandemics. These include acknowledging the essential role of testing and diagnostics among those most at risk, the need to implement robust surveillance systems and employ techniques such as contact tracing to curb the spread, and the challenges associated with developing effective therapeutics and vaccines, and importantly, addressing the severe social and economic consequences of the virus, as well as fighting the stigmatization and criminalization that is often associated with the new disease. The figure on the left here is from Shao et al. And highlights the psychosocial and structural burdens of the syndemic health problems between HIV and COVID-19. One key distinction between the two epidemic responses has been that of time. So misinformation is defined as information that is false, but which may be believed by the person spreading it to be posted in good faith. Whereas disinformation is the false or misleading information that is spread deliberately to deceive others. When HIV was first identified in the early 1980s, there were many unknowns which resulted in mis- and disinformation. As you can see here, people argued that HIV did not cause AIDS, and there were even Russian KGB disinformation campaigns arguing that HIV had been created by the CIA. There was also misinformation about the role of treatments, which we've seen with COVID-19, with debates about the effectiveness of hydroxychloroquine for COVID-19. So with the COVID-19 pandemic occurring during a highly digital era, we've also observed the pervasive spread of disinformation regarding theories that COVID-19 was spread by 5G cell phones, that it was intentionally caused by Bill Gates to sell the world a vaccine, and even the use of social media to discredit world leaders such as what happened in Ghana with President Akufo-Addo. So given this context, social media and digital news further propagate the mis- and disinformation, resulting in xenophobia, racism, discrimination, social stigmatization, and exclusion. For both pandemics, or both epidemics, the novelty of the virus has led to uncertainty and finger pointing. Even if you look at the naming of the viruses, with HIV, it was initially called gay-related immune deficiency, and the focus on 4 key populations led to further ostracism and discrimination of these populations. Similarly, with COVID-19, people have often referred to it as the Chinese virus or Wuhan virus, despite WHO naming it COVID-19, and people who were infected with COVID were often referred to as super spreaders. And importantly, both viruses, we still see criminalization and legal action being taken against people who transmit HIV to others. We still have 72 countries in the world that still have legal laws on the books to enforce criminalization of HIV. And as we've seen with COVID-19, we've heard numerous accounts of people who are not following public health measures being unduly persecuted. So what can we learn from our almost 4 decades of experience with HIV? Well, UNAIDS has taken the body of evidence from HIV regarding evidence-based interventions for reducing stigma and discrimination and applied it to the context of COVID-19. They propose that all of the proposed actions taken to curtail stigma and discrimination as it relates to COVID-19 be rights-based and community-led, with special emphasis on populations that are being left behind. The recommendations fall along these 6 key areas listed here, and a wide range of activities, including developing or modifying anti-stigma materials, providing PPE to families, communities, and healthcare workers, offering counseling, measuring stigma systematically, developing non-discriminatory workplace programs, ensuring fair access to financial support programs, implementing strategies to facilitate learning while reducing existing social and racial inequalities, establishing differentiated models of care delivery, using science to actually inform and educate constituents, and providing legal assistance to those in need are just some of the recommendations that can be found in this document. Other solutions worth mentioning include ensuring broad community engagement and support. That might be in the form of identifying and educating key opinion leaders, which we know works with HIV, or using social influencers to interrupt the dissemination of mis and disinformation. We can also ensure that as effective vaccines are identified, that the community is at the table working with scientists and politicians to figure out how to best disseminate and get access to those vaccines. We should also strive to be intentional with our language, as we try to do with persons living with HIV. And we can partner with people who've been affected or infected with COVID to dispel the myths and to speak to the truths of having COVID-19 and surviving. So in sum, the coronavirus pandemic is an evolving situation that's had unprecedented global impact, but disproportionate impact on certain populations and regions of the world. The unknowns and uncertainty, given the novelty of the virus, have led to stigma and discrimination that's similar to that we've observed with HIV. And therefore, we have to capitalize on our knowledge from prior pandemics and epidemics to try to systematically address these racial disparities, stigma, and discrimination. HIV provides many examples of how to confront and reduce stigma and discrimination with COVID-19 and other infectious diseases, and can lay the foundation for that response. So with that, I thank you for your attention, and I look forward to the discussion.
Thank you, Amanda, for that great talk. We're now going to move on to the next speaker, Linda Gale Becker, who's going to present on how stigma is impacting on the 90-90-90 goals. I'm sure you all know Linda Gale. She is the Deputy Director of the Desmond Tutu HIV Centre at the Institute of Infectious Disease and Molecular Medicine in Cape Town, and the Chief Operating Officer of that foundation. Linda Gale has a wide range of experience in HIV, tuberculosis, and indeed other infectious diseases, and of course was the past president of the International AIDS Society. Linda, we really look forward to hearing from you.
How stigma is impacting the 90-90-90 goals. Well, we've seen a number of eras in the HIV epidemic in the last 40 years. Certainly at the beginning was huge death and despair. Then hope, and we've really seen the epidemic become a chronic sustained epidemic. More recently, there's been narrative about the end of AIDS. We certainly have come a long way, and most pronounced perhaps in the era of treatment. Antiretrovirals have made a huge difference in terms of how we perceive HIV. Most recently, we've also seen fantastic innovation around primary prevention. And happily, with the rollout of antiretrovirals, we've seen morbidity and mortality drop around the world. The area we have been less successful in, many would argue, is that of HIV-related stigma, which seems to have evaded us in many ways. We could also argue that of late, if anything, we've seen an exacerbation in stigma and discrimination around the world, as we've also seen the world retreat on human rights in a more wholesale fashion. And this was really highlighted in the International AIDS Society annual letter in 2019. This survey over 5 years of countries, adults in countries, and levels of HIV stigma, how adults perceive people living with HIV and their discriminatory attitudes, you can see really an extraordinary prevalence of these attitudes around the world. So what are the levels of stigma? What kinds of stigma are we talking about? And this publication in 2014 nicely describes structural stigma, where stigma occurs within social conditions, cultural norms, institutional practices. This notion of public stigma, where commonly held negative beliefs occur in the general population, discrediting a particular group of people. And this inevitably leads to self-stigma, where a person becomes aware of the public stigma and then internalizes the beliefs. And we know discrimination is a direct action that results from stigma. Stigma and discrimination have held the HIV response hostage, particularly where leaders have lacked courage to tackle the questions that would allow for an effective HIV response. We've seen criminalization and discrimination of key populations, criminalization of HIV non-disclosure, exposure, or transmission, the lack of implementation of harm reduction approaches, poor service of incarcerated populations, harmful gender norms, gender-based violence, homophobia, other beliefs, and inadequate comprehensive sexual health education, to just name a few. So when we think about these populations who are particularly highly burdened, but also ironically have the worst access to services, they often fall within the categories of young people who inject drugs and use drugs, people who sell sex, young men who have sex with men, but other populations such as transgender people, incarcerated people, young refugees, migrants, detainees. And so even as we think about leaving no one behind, we are leaving large tracts of the world behind. Most of the infections in the rest of the world, other than East and Southern Africa, occurred in key populations, 62% of infections. And even in this part of the world, East and Southern Africa, a large part of the new infections were in key populations, almost 1/3. Why is it that we see more infections in these populations? Well, too often, aside from stigma and prejudice, there's poor information, inadequate services, criminalization, poor social protection, violence, and incarceration. And here you see in this set of data, looking at HIV incidence amongst MSM in a number of different parts of the world, although incidence was similar. The number of people who knew their status, in other words, had recent testing, was very much dependent on whether their countries criminalized same-sex sex or not. Similarly, we know that harm reduction practices are poorly implemented across the world, really leading to unnecessary infections in those parts of the world where drug use is the main cause of HIV. Eastern and Southern Africa see most of their infections in young women and adolescent girls, but even here we consider them a key population for the reasons that services are inadequate. There are low levels of school completion, inadequate information, high levels of gender-based violence, poor access to services, poor social protection, alongside, of course, stigma and prejudice. And because of these bad policies that reflect more ideology, prejudice, and bias rather than science or evidence, those most vulnerable to HIV are deterred from accessing the services they need the most. So there are targets that are before us, and we, talked about these well in advance of 2020 and 2030. Unfortunately, these targets, the 90-90-90 targets, we have missed in 2020 in many parts of the world. And the idea here was that if we accessed 90% of the world for testing, 90% of those who were positive got onto treatment, and 90% of those were virally suppressed, we would see a consequent reduction in HIV new infections. But hand in glove to that, of course, is the recognition this cannot be attained unless we also do something about stigma and discrimination. And here you see the goal for 2020 was zero discrimination. We have, of course, fallen short of that. So what has been the impact of that not meeting that goal on the 90-90-90 targets? Well, we know that whilst we have made some gains, the progress is well off the mark. And 62% of new infections occurred in key populations where people struggle to access sexual reproductive health services. Many are criminalized, and many face a great deal of stigma because of that criminalization. And so as we look at the whole cascade, we know that stigma and discrimination plays a role in every single aspect of the cascade, all the way from demand creation, encouraging health-seeking behavior, all the way through to actually retention in care and viral suppression. And so in this publication from UNAIDS, now somewhat dated, 2005, much of what was said about stigma and discrimination still holds fast. So where on that cycle of the cascade, we know stigma plays a significant role, and I draw your attention to this document. It is online, and that particular graphic, which shows just the places where stigma and discrimination plays a significant role in the cascade. So let's turn to the first 90, and we know that stigma can drive lower rates of uptake of testing. There are several interventions that can address that, and chief among them are knowledge. So by increasing knowledge, we can trigger changes to stigmatizing attitudes. Knowledge and attitude improvements can trigger changes in behavior with increased HIV uptake. It is interesting also, this paper from TARP and others in 2018 conclude that knowledge alone can lead to testing uptake, even when it doesn't necessarily change stigmatizing attitudes and behaviors. Not to forget other biomedical interventions such as self-testing, which of course can combat stigma. And here a paper by Perez and others showing that the power of self-testing, being able to test alone, how that can also reduce fear of community stigmatization and enable people to test. So there may be other ways to tackle this problem. We know that stigma can compromise adherence to HIV treatment, and in this paper, an important one, looking at what were some of the roles of stigma in undermining ART adherence. And public stigma can play a role here, where adaptive coping and social support processes are undermined. Structural stigma can play a role, really again, where a person living with HIV is unable to overcome structural and economic barriers associated with poverty due to stigma. And then finally, of course, self-stigma playing a very significant role, undermining an individual's recognition that life-saving treatment is really key to their well-being. And then the third 90, that of viral suppression, staying in care and making sure that antivirals are taken regularly, can be undermined. And here, healthcare facilities themselves can play a very significant role. So this paper that I highlight here helps us to think through ways that healthcare facilities can reduce their discriminatory practices, reduce stigma, and enable people to stay in care and to take their antivirals regularly. So that may include increasing information, sensitizing healthcare workers, bringing in peer-led programs, allowing for coping mechanisms, and bringing about structural change, which really raises the question of differentiated care. And we know that differentiated care, differentiated service delivery does address stigma. In order to be client-centered, we have to overcome stigmatization. And this becomes a very important concept all the way through the whole cascade. So again, reminding you that differentiated care goes all the way from prevention through to viral suppression. Viral suppression, of course, can be a destigmatizing concept. So ironically, although stigma can affect the third 90 can cycle back to reduce stigma. And we know that individuals who are virally suppressed are uninfectious, and this can certainly help with self-stigma, but it can also help if we educate healthcare workers and others, can be a very important factor to help those individuals overcome a lot of discrimination and stigma that exists in the world today. So it really becomes a full cycle. So in my last couple of minutes, here are some other approaches that we can learn from other health domains, such as substance use and mental illness, to bring into the HIV arena to say, what can we do? Well, of course, for adolescents, it's very important to start at the very fundamental level, school-based programs and also social media, the internet, increasing knowledge and understanding to reduce stigma. Education at the heart of this, misinformation, countering inaccurate stereotypes with factual evidence can be really important. What about protests and advocacy? Of course, advocacy, advancing civil rights, formally rejecting stigma, very important, and this speaks to grassroots movements. The need to reduce social distance, a difficult one to discuss at this time of COVID, but there are other ways of reducing social distance, using social media, for instance. Making contact, very important. Again, doesn't have to be physical contact. It can be done virtually. And then peer-led, peer services, a really critical way to address some of these stigma issues. So interesting ways for us to think those through. Two documents I've already alerted you to the now somewhat dated UNAIDS document that I think still holds true, but also bringing home this annual letter that was written by the International AIDS Society in 2019, where its last page really documents some concrete agenda items for all of us, alerting you to the Global Partnership for Action to eliminate stigma, the roles that governments can play, the need for new funding, prioritization of stigma mitigation, the role that healthcare workers can play, and of course the role that people living with HIV themselves can play. But we cannot rely on people living with HIV alone. It is worth saying in the last few seconds that stigma reduction efforts remain chronically underfunded. And of course, this is something to bring home in 2020. Community mobilization information needs funding. Interpersonal communication so key, civil support, civil society support and peer-led programs all need to be effectively funded. We are making gains in the general population, but there is a great, great risk that we are leaving large tracts of key populations behind. And this is because of fragile, underfunded, fragmented, stigmatizing, and inefficient health systems. John Cohen penned this important piece in 2018, and I would just say that the AIDS epidemic is far from over. We will not reach the UNAIDS targets and control HIV unless we end HIV-related stigma. There are many parts of the world where stigma continues unabated, and in those places, the epidemic is far from over. With that, I would just acknowledge my research assistant, Carrie Pike, and these two very important documents, as well as many other research materials which I did highlight through the talk. Thank you for listening.